Okay, we are live now. So hello everyone, and thank you for joining us. Welcome to CDEP's conversation series on global health. This is our 9th webinar. Today we'll discuss the utility of mathematical modeling in understanding disease dynamics and informing policy in the context of the COVID-19 pandemic. I'd like to thank our panel today for joining us to share their views and experiences, because we all know that this is a very busy time, especially for modelers these days. So we're very happy to have with us Dr. Eili Klein, a senior fellow at CDEP and associate professor of emergency medicine at Johns Hopkins. We have Dr. Silal from the University of Cape Town. Dr. Silal is Director of Modeling and Simulation Hub Africa and an associate professor at the Department of Statistical Sciences at the University of Cape Town. We also have Dr. Brian Wahl, assistant scientist at the Johns Hopkins Bloomberg School of Public Health. We also have Chadi Saad-Roy, a PhD candidate at the Quantitative and Computational Biology Department at Princeton University. So we will start the webinar with some specific questions for the speakers, but we will have about 10-15 minutes at the end of the hour to answer your questions. We see that we have a very international audience today, so we look very much forward to the questions you might have. You can include them in the Q&A section in the Zoom app. Before we start today, Dr. Ramanan Lakshminarayan, Director at CDEP, would like to say a few words. So over to you, Ramanan.
Thanks, Urta, and welcome to all of you. As Urta mentioned, this is the 9th in a series, and it's been a really exciting series. We're going to hope to close with 10, so there's only one left. Now, modeling has been something that's very core at CDEP. It's also something which has taken up a lot of our time, particularly the COVID modeling for the last, I would say ever since last February, when we knew that we had something to really worry about here. And we've done this not just in the United States, which is, what you'll hear from Eili, for instance, in the state of Maryland. You'll hear about, the work that has been done in South Africa from Dr. Sheetal Silal, and the excellent work that Chadi has done with a group at the Department of Ecology and Evolutionary Biology at Princeton. And last but not least, Brian Wahl, who's got some amazing work on disease modeling with respect to COVID, and especially COVID epidemiology that's about to come out, which is based on data from India and the state of Uttar Pradesh where he works. Now, the challenge of modeling COVID has simply been that the questions asked of models have often run far ahead of the data or even knowledge about the virus. And but at the same time, I think it has been a great opportunity to educate people outside of health, or perhaps even within health, on the role that mathematical models can play. And I think knowing what models can do, but also knowing what they can't do, is really, really important. And I think we need to see them as guideposts rather than exact predictors of what will actually happen. At CDEP itself, we could, at the very start of the pandemic, predict, quote unquote, predict that something as fast moving as COVID would end up resulting in hundreds of millions of cases in India, for instance. But sometimes the modeling also needs to be accompanied by a communication exercise where people are able to understand what this really means. And sometimes because we're saying things in fairly neutral terms, that the hundreds of millions of cases, the vast majority might be mild, but people are scared of a new virus and of infections, and therefore the response might not be quite what we want. It turns into fear, or the converse, which is that you say that this is not a lethal variant, for instance. If someone were to say that, then the response tends to be much more of taking the variant very lightly and not really protecting themselves. And last but not least, every time I'm asked this question on any sort of media about the modeling, and I often say two things. One is that anything we say today will probably be out of touch in 2 weeks because the science would have changed, or our information set would have changed. And the second is that of the three factors that determine how diseases move, the virus, human behavior, and government policy, the most predictable is the virus. the less predictable is human behavior, the least predictable is government policy. And I think we've seen this, in all waves of this pandemic, and particularly, during this Omicron, the most recent, revelation that we have a new variant, which again was no surprise that we would have one. But of course, the responses there have been absolutely astounding, and not astounding, not in a good way. And of course, this really reflects poor understanding of what the science really is trying to communicate, and what people, both the lay public and the policymakers, are hearing. So the challenge of modelers is no longer of building great models. It's really of building models that can, can anticipate some of these in terms of behavior and government policy. But then the challenge for modelers is also in terms of communicating to a much wider audience than we've ever had to do before. So again, we're delighted to have, four of the best people working on this around the world, and look forward to hearing what they have to say. Thank you, Arta.
Thank you, Ramanan. I guess we are ready to start. Start with Chadi from Princeton University. So starting from the earliest infectious disease models, epidemiologists have tried to use models to explain and predict disease dynamics. In your opinion, how does modeling serve in understanding disease transmission? And how did this change with COVID-19 pandemic, especially following the increase in data availability?
That's a great question. Yeah, thank you very much, everyone, for having me. It's my pleasure to be here and to participate in this conversation. So I guess to really address this question properly, we have to go back to a long time ago, and this field is a rich history, and probably foundations start with Daniel Bernoulli in 1766, looking at endemic smallpox. And these concepts are pretty historical, and then more recently have been formalized with things that we know better, such as the SIR model, where individuals are susceptible, infected, and then recovered. And that was introduced in 1927 by Kermack and McKendrick. And then Ronald Ross, big pioneer of mathematical modeling as well, on malaria. And so then since then, it's just been refinements and a number of developments in mathematical, statistical, and biological literatures. And so I think it's been a long time since a lot of these issues have been present and a lot of theory has been developed, but the COVID-19 pandemic has really brought these to light and in public discourse, really. So I guess, I was trying to make a list of the things that models can be useful for, and obviously my list is very, very limited, and probably there are many more uses. But what I was thinking about was that you can use models to determine exponential growth rates. So that was, big thing. Still is. How fast are cases growing? And then that kind of ties into determining this R naught, right? This basic reproduction number. How many, and that's the definition here, is the number of new infections that arise from a single infection in a fully susceptible population. And related to that is the dispersion of infectiousness. So these models can help us infer that, and then we learn something about the biology of the disease, which then tells us something about the public health interventions we need to in place. On a different side of things, you can also use models to aid in underestimating reporting of cases. So as we all know, not every infection leads to a positive test. A lot of individuals just won't get tested, and that's an underreporting. And so that's a severe issue in prediction, and models can aid us to determine this underreporting rate. There's also, and Ramanan alluded to these as well, but trying to use models to forecast much more finely what will happen. And so there's been huge push for doing that, and I think that's what the public wants sometimes from models. Well, what's going to happen in the next few weeks? Like, well, what can we say? And that's usually a very arduous task, but an important one nonetheless. And a number of very great groups have done substantial leaps in this front. And then there's the work I've been more involved in, which is more to generate possible qualitative outcomes and see how they're shaped by different uncertainties. Yeah, like I said, there's many more uses, but if we focus in on my own work, we can see as an illustrative example of how modeling can progress throughout the pandemic. I initially started, we were looking at initial uncertainties with respect to the strength and duration of immunity, and how if you properly account for this in models, then you can get a really wide range of outcomes. And back then, vaccines were in development, but we didn't really know what shape or form they would take. Then vaccines were developed. Some are 2 doses, and then the question became, should you space the doses and deviate from the manufacturer's recommended spacing, or should you not? There's a lot of considerations, and there's epidemiological considerations and evolutionary ones. And so the next thing we did was refine this model, and then we refined it, and we're able to evaluate the possible outcomes again by just generally like qualitative predictions, more what might happen depending upon what the parameters are. And then more recently, which is still at the forefront of everyone's mind now again, is this question of vaccine equity and driven by vaccine nationalism. And so more recently, we examined, with extensions of our previous work, what happens if certain countries have high access and others have low access. So I think in my own work, you can kind of see the trajectory as the questions arise in the public health discourse that we're addressing. So this is, I guess, a open-ended question, but hopefully I've addressed some of the key issues.
Yes, thank you very much. Thank you, Chadi, for that introduction. We have one more question for you, and that has something to do with the conceptual limitations of modeling. So models provide a framework to understand complex concepts, and what are the current conceptual limitations with modeling studies?
Yeah, so that's another great question, and actually kind of ties into the end of my answer to the first question. So even with, as you can see with, as I was describing, so we've had this simple model that accounts for the strength and duration of immunity, and once we refined it to a number of, to 2 doses, then the model increased dramatically in complexity, which actually is an example of something that's important here, right? So usually you can make very complex simulations, complex models that are with tremendous complexity, and that can replicate, you know, we can encompass a lot of important aspects, but they're much less tractable. And then on the other hand, you can make simple models that are tractable, but then they gloss over a number of important features, or they make assumptions about a number of important features. And so I think the idea would be to try to increase the tractability of the more complicated models to properly account for different behaviors. And so that I think is a major limitation. And I think this, as a specific example beyond my own work, we can think of the interplay of human behavior and disease dynamics. So this is a tremendous problem, and there's been huge development in this area, but it's still very much so that the models that you use to generate this will be along this range. And the more simple you go, then the more you're glossing over, and probably the less accurate the predictions might become. So you really have to balance this always and figure out how complicated you want the model to be. And so, and even, you know, when we extend it to vaccine nationalism, now we only have 2 countries. This is the simplest possible extension. Already, most of the details, you have to rely upon numerical simulation, and the tractability there is lost. However, on like another hand, there's some other, I think the pandemic has led to a number of like really interesting breakthroughs on potentially previous conceptual limitations. So there's some interesting work by James Hay et al. In 2021 in Science, where they use CT values to infer epidemiological dynamics. So that's really using this abundance of data to really try to predict the shape of the pandemics. And then there's been this like great collaboration between engineers, biologists, and interdisciplinary scientists to understand transmission and aerosols and droplets and how these things function with humidity and temperature and environment. And I think a good citation for this might be Morris et al. Eili 2021. And I think that's also been like these revolutions where you're using these novel data, which usually is what conceptually limits the models. There's just this there's this limitation of data that then feeds back to the limitation of the model. Now here we're using, individuals have been able to propel the field forward by combining new types of data with interesting modeling, novel modeling approaches, which probably will lead to a number of works in math, stats, and biology, and with public health relevance. hopefully that addresses your question, Rita.
Absolutely. Thank you so much. And I was just going to add that if you'd like to share a link to the papers you are referring to or any relevant recent articles from your work, please feel free to share it in the chat.
Oh yeah, sure. Yeah, sounds good. I'll do that.
Share it with everyone. Thank you very much.
Thank you.
Okay, then Eili, we have a few questions for you on the complexity of mathematical modeling. So how can more complex models help to understand the multi-scale effects of diseases? For example, is it possible to integrate models to understand how within host dynamics of diseases can impact population level disease transmission?
Yeah, hi. Sorry, I'm trying to share my screen. I'm gonna just
Thank you.
2 slides. If that's all right. So I think you know, with regards to the first question on complexity. So can you see my screen, Arta?
Yes, we can see it very well.
Okay, so I think the big question is, what is the goal of model, right? You know, whenever I talk about modeling, it's almost impossible not to show the quote by George Box that all models are wrong or some are useful, right? So a simple model is unlikely to represent any system in general, to exactly represent any system. But parsimonious models can often provide remarkably useful approximations. So as the complexity of model increases, and in recent years, the ability to make more and more complex models has increased dramatically, the question still remains, what's to be gained by adding all that complexity? So as Chadi said, the greater the complexity of that model, the harder it is to evaluate and understand what's going on. So, you know, if we go all the way back to sort of the chemistry where a lot of these models, a lot of infectious disease models came from, right? The PV, the ideal gas law, right? PV equals RT. It's the ideal gas law. It relates pressure, volume, and temperature to describe how gases will behave in ideal conditions. Is this model true? I don't think that's actually the right question, right? The right question is whether this model is useful and illuminating, right? And it is, right? Because understanding deviations from this model allow you to understand important aspects of chemistry. Right? And so I bring up chemistry because, of course, the SIR model in general comes from chemistry, right? It's a concept that the same way that atoms move around independently and interact and convert from one state to another, that's basically the understanding of where, or that's how models of infectious disease were originally built, right? And so, you know, we can make those more complex. We can add different aspects to that. And the question is, you know, you asked about specifically within host dynamics. Do within host dynamics impact population level disease transmission? And I guess the question I would ask more in a different way is, how do the dynamics at the individual level actually scale up and matter, right? And so you could attack this from sort of a bottom-up approach or a top-down approach. From a bottom-up perspective, the question would be sort of from a bottom-up perspective. From a bottom-up perspective, the question is sort of, you know, how do all of these interactions at the individual level actually matter, right? So you could build a model of how within host dynamics actually scale, whether it's COVID like this one is, or some other disease, and then scale up those and connect those individuals and see how that affects population dynamics. On the other hand, you could also start from a model that is more simple, right, where everyone is basically the same, and start adding variation to individuals to see where and what level of variation actually matters. So it's more of a top-down approach, and then determine whether that variation really matters or is biologically relevant. And so those are sort of two ways to sort of get at this question of, you know, how do multi-scale dynamics actually matter, and when should they be put together into models to sort of define how you want to move forward. Right, so I think that's sort of where I wanted to go with the complexity, right? I mean, I think there's a lot of different ways you could answer the question of complexity, but you know, the questions really come down to what is the question you're trying to answer. And I think, you know, we have, and I'll talk a little more about this as you in your second question, but I think the issue really is, what are we trying to answer? Do you want to know the specifics of how multi-scales actually impact the dynamics, and so you might want to build models that look to that, or do you really want to understand the model at the individual level? Or as this is sort of showing, right, they actually just built a model recently for how a droplet, how the dynamics of the scale of a single viron inside a droplet actually work. And they ran that model for a total of exactly 1/1,000,000th of a second. And that generated, you know, to do that, they had to use the biggest computers that are available now. And the amount of data that was generated from that will take years to even analyze, right? And so the question is you can't build that into another model, but you can take the dynamics and the importance of that and understand, you know, which of these parts of the model matter. Is it the network part of the model, right? How populations are connected, that really matters? Is it the airflow and the droplets that really matter? Or is it the within host dynamics within an individual host that matter? And I think, you know, for every disease, it's going to be different. And so how you want to design those models is going to be different. And realistically, no one model should probably include all of those things, because it's just going to be too complex. So the question is, how do you put together these arguably simpler models that hopefully have some parsimony to them, are tractable, and can provide answers that you can use to define either specifics about the disease that are important, or specifics about how you want to deal with public policy. And I think both of those things actually have different frameworks in terms of how you want to deal with the outcomes, right? And finally, the last thing I would mention is on the same lines, right? If I'm asked to answer questions about public policy, I'm going to build a different model than if I'm trying to answer questions about where we want to build science, right? So I might want to build a within host model to sort of define the questions that might be useful to ask in terms of what experiments might be necessary, rather than how I'm going to build that individual-based model, or how I'm going to build that within host model to answer questions at the public policy level. Those two things are different modeling techniques and have different frameworks and outcomes.
Thank you, Eili. That's fascinating stuff. So you have already touched upon my second question, but I will ask it anyway in case you want to revisit parts of it. So that was on data complexity. So as more data becomes more readily available, is it beneficial to continue refining models with more complexity? And what will the known unknowns be once we have enough data to model behavior and diseases correctly?
So I think, again, this gets back to the question that one is trying to answer, right? I think the problem is that, you know, a lot of what people view modeling for, and what people talk about modeling in the context of COVID, is how are we going to do prediction and forecasting? But as I was sort of saying, there are lots of models that can provide utility. So that within host model may not need to be coupled to a population level model to provide utility, right? And so there's a lot of different factors that you can look for. But I think when you start to talk about big data, the really crucial question is that we really need to start looking for and understanding in terms of modeling is what data is needed, right? So Chadi mentioned that somebody used CT values to help try to understand the dynamics of disease, right? Back in 2010, I saw a talk where someone was using a home-built app to track some phones, right? So people signed up, you could see how, and then they were showing how individual tracks of people moved and how their regular movement patterns defined important characteristics of daily interactions. And I remember discussing how great it would be if we could have that at a population level, and then we could track how diseases spread. Well, here we are in 2021, and we actually have data at somewhat of this scale, right? Particularly in the US, there's been all of these mobile phone data providers that actually provided this data for free. And we were all excited. We started using that model. And if you looked at the original data that people started using back in March 2020, there was tremendous correlation between drops in mobile phone data, or so drops in movement based on the mobile phone data and transmission. And everyone's like, oh, great, we can use this data to provide important information. Well, then everyone started moving around again, and there was no correlation with transmission. So the question became, how do we, what is that mobile phone data telling us? What are the important characteristics of it? And we started to dive into that data and find there's all sorts of biases. Who actually has a mobile phone? Who's actually involved in transmission? If two people are near each other with mobile phones, does that mean they're actually transmitting? Like, there's a lot of other factors that we presumably are missing that are not provided within that data. And so, now it comes down to this question of, you can't just, some people are trying to just throw lots of big data at, a model and try to figure things out using AI. And I think there's probably some there. But at a general level, I think the bigger questions are really, what are the types of data that we need to collect? And what are the types of data that we need to use to inform important aspects of a model, right? And this gets to this question of, what does everybody really want to do with those models? And I think a large portion of it is, people want to do forecasting, right? And that there's been a huge push within the US for this specifically, right? So the Congress actually appropriated money to generate a new pandemic forecasting or forecasting center. And the idea is that it's based on the way we developed weather models, right? And I think, it's useful to think about how accurate weather forecasting is, and how I don't think people have fully understood the weather parable, right? So I'm not going to argue that weather forecasting hasn't dramatically improved, and it has. I mean, weather forecasting has become really, really reliable in some instances, right? And it was driven by the accumulation of lots and lots of big data, right? So first we had radar, which emerged in the 40s, and that helped provide some predictability, but then you needed more and more data, right? So then we have weather satellites and ground level humidity collections and all of these different data streams, which all are all pushed into these models that can provide two types of models, right? So the first is sort of this short-term weather forecasting, right? So we can see this both in this slide here, where you can see we've got hurricane forecasting, right? So therefore, hurricane forecasts have actually become really good, right? But there are actually lots of agglomerations of models. So this is back in 2012, you have Hurricane Sandy. You have all these different models, and many of them all predicted this track where it went to the left, right? And so this is what you see typically on TV, where you get this like cone of uncertainty. And that uncertainty comes from all of these different models, right? But you'll see even two of the models had just very, very different outcomes, right? So there's this concept that they've sort of put together, putting lots of models together. But those forecasts were pretty accurate at about 2 or 3 days, which is useful. Now I have an app on my phone which tells me what the weather is going to be like in the next 15 minutes. Also very useful for what I'm doing in the next couple hours, right? But unlike weather, disease is very different, right? Diseases, if I make a forecast for the weather, people aren't going to, whether or not people change their behavior because it's going to rain isn't going to change the fact that it's going to rain. But on the other hand, if you make a forecast for disease, that can actually change how people are going to behave, which ends up changing the outcome, right? So the important question though is, what are people going to do with these forecasts, right? And I think that's where the difference and the weather question parable differs, right? So, realistically, many of these mechanistic models and all of these modeling systems that have been put together by CDC have been pretty good at predicting stuff about 2 weeks out. The question is, what is 2 weeks out? Is that useful in a disease context, or do we need something different, right? And even if they're accurate, what are we going to do about it, right? So all of these weather predictions, right, all of these things have told us that we can now go and do specific things to try to save lives, right? And so we have hurricane warnings and we evacuate certain areas. What are we going to do if the forecast for flu is high this week? Will that change how people go about their day? Do we want to have people wear masks in certain contexts? Do we mandate that? Do we just suggest it? Maybe we want to change how schools are in session and all the things. And as we can see, at least in the US, that has caused significant complications in terms of trying to adjust and force how people behave becomes problematic in many ways, right? And so the question, I guess, is we can get lots and lots of big data and we can maybe improve our models, but I think Ramanan alluded to this right at the beginning, is those model predictions have to drive something. And I don't think anybody has made a decision as to how to take these model outcomes and use them for any type of specific actions that will be of utility in changing the outcomes, right? So even prior to this, there used to be these challenges for predicting when the peak of flu would be. And while I guess useful in terms of generating improvements in models and predictive power, I always questioned what was the hospitals going to do about it? The hospitals weren't listening to this data. They weren't changing their behavior. They weren't changing their operations. So what was the utility of that? And I think that's one of those big questions that we need to answer, sort of outside of modeling, but more of a societal question, sort of how to deal with what are the predictions of models.
Great, thank you, Eili. Very interesting description of forecasting and behavior. I think we may have a question or, oh no, it was just a comment on that. So yeah, thank you. We are now moving on to our next speaker, Dr. Brian Wahl. And I will, yeah, sure. Sorry, can you hear me?
Yep, we can hear you.
Okay, perfect. Sorry, there was a little bit of a glitch. My screen was completely frozen. So, so Brian, throughout the COVID-19 pandemic, modelers from many other fields, including physics, have attempted to model diseases. How has the field of epidemiology benefited from these contributions?
So first of all, thank you for having me. And I think it's important to note up front, as Eili was mentioning, that mathematical modeling and epidemiology has benefited tremendously from other scientific domains. So the law of mass action from physics and in chemistry really forms the basis of our standard compartmental models, the SIR models that many of us have been using to model the spread of COVID-19 around the world. And so cross-pollination of ideas and methods is incredibly important and is fundamental to the scientific process. And so there have been, I think, many ways in which modeling has benefited from other domains, physicists in particular, but also mathematicians and several other domains, computer scientists who have engaged in mathematical modeling around COVID-19. There's also the not so good aspects of it, and I'll maybe describe some of the limitations that I've observed as well. So you know, one important component is that there were many models that were developed, especially in the early days of the pandemic, and it wasn't the absolute number of models that was a contribution in and of itself. But what we did see was that the best performing models seemed to be the ensemble models. There were a lot of examples from the US in which ensemble models eventually provided at least 2 to 3 or so weeks out the best estimates of the trajectory of the epidemic in many settings. And those ensemble models may not have been possible without the contribution of models that were developed by physicists and mathematicians and so on and so forth. Something that I think people, I have been surprised that people find surprising is that not all epidemiologists are mathematical modelers. I think I know many more epidemiologists who are not mathematical modelers than who actually are mathematical modelers. And so I've seen a number of examples of physicists in particular, but mathematicians and also epidemiologic modelers working with epidemiologists who don't have expertise in modeling to develop models of both predictive models, but also I'll give an example from some of the work that we did in India. I do mathematical modeling, but also collaborate with physicists and developed a mathematical model to look at optimizing vaccine introduction strategies in India, and also looking at school reopenings using models that I'm not, I don't normally work with, and working with colleagues who work more readily in for example, agent-based models, we were able to address some of these key questions related to school reopening. Both Chadi and Eili mentioned some of the integration of say, for example, fluid dynamics into models, and of course, physicists are really well positioned to describe some of those properties, and working with epidemiologists in integrating those into existing or new mathematical models as well. And so that I think has been an important contribution. I would just maybe end by saying, it hasn't been a smooth, it hasn't been completely smooth. I mean, I think there's examples of non-epidemiologists engaging in mathematical modeling that that I think may have furrowed the brows of some epidemiologists. That's not to say that epidemiologists also didn't develop models that were not useful, but there were a couple of things that I found interesting. One is I think the balance between getting if say for example you're developing a compartmental model, developing these highly complex models with numerous complex compartments, striking a balance between that and a more parsimonious model that has strong assumptions. I think that balance I saw tension in that among modeling efforts where epidemiologists were not fully engaged. Other epidemiologists may have also experienced this kind of rediscovering of results that epidemiologists have maybe known for years. And so there's examples that, from my work where someone who I don't work with, but who had developed a model came to me with this very exciting finding of how to estimate a vaccine-related parameter. And I was like, well, we don't need mathematical models complex mathematical models to estimate that. We can estimate that a bit more directly. So there have been some I guess entertaining aspects of this as well. But overall, I think the collaboration. I think if there's a silver lining in the pandemic, I think multidisciplinary teams working together to describe transmission dynamics of infectious diseases would definitely be one of them. And I'm hopeful that that this collaboration between fields that may have been seen as being disparate, that continues looking at other infectious diseases as well.
Thank you, Brian. I have one last question for you, and that's on the future of epidemiology with more advanced tools from machine learning and artificial intelligence.
Yeah, so this is a great question, and you know, there have been examples of machine learning being used in models for parameter estimation, for example, in COVID transmission models. I'm sure we'll see more and more of this in years to come, but I think I want to go back to the point that Eili was making and what I was, you know, describing just previously. You know, this trade-off between parsimonious model and a simplistic, or not a simplistic, but a simple model with strong assumptions that can give the right answers to a question that maybe you're trying to ask. And again, this comes back to what is the question that you're trying to answer, and Eili was making a really strong point that we think of mathematical modeling as many times with prediction models and looking 2 or so 3 weeks out in the case of COVID, but there are examples of mathematical modeling where qualitative answers can also be incredibly helpful. And so thinking through how appropriate tools, whether it's machine learning, artificial intelligence, or otherwise, are really tailored to the questions that you're trying to address. Ultimately, I think beyond even mathematical modeling, I think there are a lot of opportunities for advanced computational methods, AI, and so forth, to advance the field of epidemiology. But I think there are also challenges that need to be taken into account as well. And so, what we can use AI and machine learning in causal hypothesis testing. There are, of course, risks associated with identifying spurious relationships, or which is probably maybe more likely the case, relationships that are not necessarily meaningful from a clinical or a public health perspective, but maybe because of statistical power or the kinds of tools that are being used are identified as being causally linked. And so I think this speaks to the importance of strong epidemiologic training in epidemiologic reasoning, especially and collaboration between those who are working to develop AI tools and epidemiologists. And maybe I can just quickly share one slide from some work that I've done previously. If you're able to see, so this is from a paper called "Artificial Intelligence and the Future of Global Health," and we looked at along the entire value chain, from development of AI tools to deployment, the need for user-driven research agendas that align with digital principles that have been developed, in consensus with experts from multiple fields, but also with guidelines on statistical, ethical, and regulatory standards as well. And so, I think we're a little bit in at the frontier of using AI and in epidemiology and in global health. And I think more and more having some of these standards in place is going to be really important for ensuring that the field benefits most greatly from these new developments. Thank you.
Thank you very much, Brian. We're now going to move on and talk a little bit about COVID modeling in the context of health policy. And for that, we have a couple of questions from Professor Sheetal from the University of Cape Town. So one of the challenges with the COVID-19 pandemic, it was mentioned also today by the speakers, by all of the speakers, is that is the issue with not fully understanding the self and the parameters associated with specific characteristics. Now, given those challenges, forecasting will result into large uncertainty bounds. And how can modelers effectively convey these uncertainties to policymakers without distorting the public health messaging or without undermining the usefulness of these models?
Hi, firstly, thanks so much for inviting me to be on this panel today. I'm just going to share my screen just with a few supporting slides. So my involvement in the COVID pandemic has been from the perspective of supporting policy and primarily for that reason and that purpose. So all the models that we developed were particularly to be answering questions on the nature of the epidemic as it evolved in South Africa, variant after variant, with and without vaccines, and then to support decision making at a very large scale. So along on the smaller side, it was about preparing hospitals from the points of ordering drugs and having enough staff at each hospital, all the way and having enough beds, all the way up to at the presidential level of making national policies on lockdowns and curfews and so on. And so when the South African COVID-19 Modeling Consortium was founded, which is a group of modeling units who've come together from a variety of universities in the country, we had to make a decision on the kinds of modeling that we would provide. And so to answer your question directly, we did not attempt to forecast for very long periods. We rather chose to do short-term forecasting, but then use a scenario approach to our long-term models. We knew that in order to be most effective in decision-making, we needed to make long-term projections at a time when almost nothing was known of COVID. And that's sort of why I've labeled here things as, the knowns, the unknowns, and the unknowables. Some, even 4 waves into COVID so far, many aspects of the disease, of population behavior and response to restrictions and so on, much of that is unknowable. Certain unknowns have become knowns or better understood throughout the epidemic. But what that means for us and how it works towards gaining and maintaining public trust and maintaining government trust of your model so that your modeling evidence can be a key input in decision making is through constant adaptation. So firstly, we have a variety of models. We use statistical models with you can see here confidence bands and doing short-term forecasting at a admin level 1 granularity. And so by forecasting cases and hospital beds, say 2 weeks into the future, you're giving an idea of immediately what's going to happen. And of course, short-term forecasts will tend to have smaller uncertainty bands and be better performing than trying to figure out what on earth's going to happen in 6 months' time when we have absolutely no idea as to the emergence of variants and population behavior and so on. And so then with the long-term forecasting, we adapt our models, our sort of compartmental models time and time again to take into account new strains and so on, each time generating a set of scenarios or something like this, where you can gain confidence by showing, look, our models are adequately capturing the data in the background, and then providing a set of scenarios as to, based on certain assumptions, what the future might hold over the next couple of months. And then you gain public trust by, and for us, it was honestly more important to have government trust by repeated presentations, repeated engagements, and almost a constant set of meetings going on to describe your models, describe your changes and the assumptions that you're having to make. And so moving forward from some of the discussions or some of the points raised by the previous speakers, we have learned in our experience of modeling, not just in COVID, but throughout modeling of all diseases, that mathematical modeling is not the domain of the modelers alone. It is multidisciplinary. So our modeling consortium, for example, takes we validate our projections with epidemiologists and all in the manner of clinicians, intensivists, virologists, but also the public health specialists as well as the economists, and we feed our modeling results into macroeconomic models and so on, so that what we're able to do is to provide evidence on the whole system in which the disease is actually transmitting. And in the context of modeling for an LMIC, like South Africa and other LMICs that we've worked in, you have to take into account the context, the issues with the data. We can't just accept, whether it's big data or small data or any manner in between, we can't just accept the data as it is. To understand the underlying data structures and the flaws in the data are all vital to contextualizing your model output. And that helps in gaining the trust and the buy-in from your government partners as well as the public, when they can see that even though you may not have the most complex models. So for us, we had compartmental models, not agent-based models, simply because reliable data do not exist to train agent-based models in country. But so the public are aware of certain heterogeneities not being captured, but by contextualizing your results from a simpler or less complex model, you can regain that trust of the public, and then continue to have their interest in the future updates of your model that you're providing. Yeah, over to you, Atta.
Thank you very much for those insights. Very, very interesting. Very interesting. So we have another two-part question for you, and that's in what ways do models and statistics address current health inequalities, and do logarithmic biases in artificial intelligence exacerbate the inequality gaps?
Sure. So I think, I was recently participating in a WHO consultation on exactly this topic, and there was a discussion of, do the data sets exist for models to take into account these heterogeneities and these health inequalities that are particularly relevant in all countries, I'm sure, but particularly the case in LMIC. And one of the outcomes that came out of that meeting was that it is not always necessary to directly include this data into models in the form of further stratifications between income groups, for example, because there are challenges with having adequate data to train your model for all these levels of heterogeneity that you would like to include. And so going back to the topic I raised earlier, being able to contextualize your findings for a particular area with respect to aspects of health inequalities like demographic differences, historical differences in how data have been captured. And one example of that is, I come from South Africa, we've had apartheid. So for many in the Black or non-white population, historical data it does not exist, or data prior to from certain years are simply unreliable because it excludes large parts of the population. Likewise, taking into account access to healthcare, that you may say have predicted that we anticipate admissions in one area to be at level X, but actually if the population doesn't have much access to healthcare, you're going to see much lower admissions in that particular geographic area, but you could find higher deaths when you measure excess mortality, deaths occurring from disease both in and outside hospital. So being able to contextualize these findings and understanding again how biases in the data and how data are collected exist, these are other ways in which models can help to address health inequalities instead of exacerbating them. But of course, I think what is key to something like that is making sure that the people doing the models for an area are empathetic and have that contextual understanding of the area for which they are modeling. Otherwise, this level of knowledge is often missing. To address the second part of your question on the use of AI exacerbating health inequalities, I think that whether it were big data again or any other size of data, the blind use of data and blind interpretation of any model without contextualization can result in negative outcomes, whether you used AI to develop your models or you use any other method. And so factors of health inequality, like, we have disparities in living and working conditions and access to healthcare and systemic racism and so on. These all can lead to a disproportionate level of vulnerability to disease. And these are not always uncovered or able to be understood in large data sets or by our algorithms that we seek to implement. And so we can have methods that rely purely on data for predictive capabilities, actually exacerbating healthcare inequalities. But that doesn't mean that the methods are not suitable. Again, models shouldn't be divorced from the modeler, and they shouldn't be divorced from the context and the population for whom they are being developed. And I think that is the key to minimizing health inequalities.
Thank you so much, Sheetal. Thank you very much. Very interesting discussion with practical consequences for what we're experiencing today. So we have reached the end of the hour. Thank you very much for all your insights. I was just going to ask the audience if they have any questions for our speakers. It is the time to enter them now. Either on the message in the chat or on the Q&A section. In the meantime, if you have any closing remarks or any comments that you'd like to make, our audience is still there. They're all here. We haven't been abandoned, but we just haven't had any questions. Probably everybody is captivated with your discussion. All right. Well, it looks like we are we don't have any questions.
Oh. No, there is a question now.
There is a question. Okay. So, Eili.
Sure. The forecasting future. I mean, I think that's what everyone wants to know, right? When is this going to end? And I think, I mean, since I think the day that they closed Wuhan, I actually was in Portugal at the time. I told my wife, "Oh, we're in trouble now," because once you close a city of 20 million, it's already too late. It's already escaped, and we're gonna have a lot of trouble. But I think that what has happened since then is that this is, I mean, there's been a lot of twists and turns, a lot of uncertainty, obviously, but I think in general, what we've seen is a virus that has behaved in many ways similar to what we would have expected in a general approach, right? So if you look at the average over time, things have generally done what we would have expected. It's at the local level of things have been very uncertain. And when you look at what coronaviruses have done historically, right, they have generally gone to become these very rapidly evolving viruses that cause not generally significant disease. And, you know, the question I've sort of been saying, or the big question I've been sort of asking for a while has been whether or not this is going to be moving the same way most viruses have, or most coronaviruses have, which is towards a not a particularly dangerous virus that rapidly mutates and causes waves of infection every year, but we don't really generally notice or track it on a, you know, at a population level. Nobody is talking about it on the news. Or is it going to be more like flu, where it is causing severe disease to the point where we actually want to vaccinate against that on a yearly basis? And so I think that those are sort of the two more likely outcomes. And given Omicron, you know, where it does seem to be spreading faster, but potentially causing less severe disease, unclear what that means for people who are unvaccinated, but it's definitely reinfecting, looks like it's reinfecting people who have already been infected previously, means that it's going to continue, we're going to continue to see waves of this. And the real question is just, is this going to cause mild disease that we are going to, you know, just live with a common cold, or is this going to be something where we need to continually update the vaccines and constantly vaccinate every year, like with flu? And I don't know that the future is certain on that, but I would tend to believe that this is going to behave more like what we historically see with other coronaviruses, that it'll move towards a less virulent pathogen that causes continual waves of disease, but not particularly dangerous.
So I just have a quick question, perhaps a concluding question. At the beginning of the pandemic, it was challenging because there was not a lot known about COVID-19, but now the challenge is that we know a lot about the variants, the different variants. Is this an easier task to deal, like an easier challenge to deal with than you know, what we dealt with at the beginning? Are we better off now with all this information that we have?
Well, I can answer that
question. So.
I think, as challenging as it seemed in the beginning, I feel like in retrospect, it was an easier time that we're having, that we had then than now. In the absence of any data, you make a bunch of assumptions that you hope are reasonable and perhaps look to extremes, and you have a few scenarios of the future. But once we have all of this data, we now need to be able to unpack where conflicting outcomes are, and what are the most plausible, what are suitable to your setting. You need to be able to understand the, I think, was it Eili who raised the issue of mobility data? We also, in the wave one, brought in tons of mobility data. It was wonderful, and it helped with, assessing movement within the country. But by the end of wave one, it was literally completely useless. And so you've got to be able to unpack these data sets, and all that takes a lot more time than back in wave one, when you could actually, it was fine to have quite simple models and make a bunch of assumptions, and spending a lot of time understanding the where, why, and who your data actually represents. That would be my perspective.
Thank you, Sheetal. We have just one last question. What is the required background to become a modeler in epidemiology? I think that Brian talked a little bit about that. It's a nice way to end the webinar for everyone who is aspiring to be involved in modeling. Sorry.
Well, I think anybody could provide their insights on this as well. I think COVID has kind of changed things in terms of mathematical modeling in epidemiology, and I've seen, as I was mentioning, interdisciplinary teams working together on mathematical models, and so I think there could be many paths to being involved in work as a modeler, either directly or indirectly as well. And so I would hesitate to say this is the one path that you need to take in order to become a mathematical modeler. Interdisciplinary teams are working together, and there are several paths. That may not be satisfactory, but getting involved in work that's ongoing, studying quantitative training, whether it's mathematics or physics or other fields, I think could provide a strong foundation for getting into mathematical modeling. But I'd be interested to hear how others on the panel, the path that they took to get here and how they see that maybe changing in the era of COVID.
So, I mean, I probably have the strangest path to becoming a modeler, because out of college, I worked in IT actually for a while, doing web development and things like that, and then went back and studied health policy, and somehow landed a job with Ramanan, where one day, and I was working on epidemiology type of projects, and a colleague of Ramanan came in, David Smith, and he was about to go on maternity leave or paternity leave because his wife was about to have twins, and he had some models that had to be finished. And so in an hour, he dumped everything he knew about malaria modeling onto and said, "Here you go." And I didn't see him for 4 months, and I just had to figure it out. So I don't know that I mean, my background at that point was I knew how to program, and I had a background in math. I mean, I think becoming a modeler, anybody can call themselves a modeler. That's not the point. I mean, I think the question is, what do you want to do with that, with becoming a modeler in epidemiology? And there, I think Brian's point is that there's a lot of varied things that go on, right? And many of them are now interdisciplinary. So the question is sort of, where do you want to find yourself in 5 or 10 years? And do you want to be in academia? In which case, you probably want to be in an academic setting. If you want to be in government policy and helping to interpret models and drive policy, then that's a different pathway that you might want to follow. And I think that it's more what, like with anything, what do you want to do with anything that you study and learn about? Whether it's, modeling, or whether it's epidemiology, or whether it's medicine, right? I mean, all of these things, there are people who go to medical school but don't want to be doctors in the same context that you usually think of, right? So it's really about what you want to do with the concept of modeling. And as I said, when I was talking, modeling can be useful for population level modeling. And when we talk about SIR models, that's a lot of what we're talking about. And when a lot of what COVID-19 is you get a lot of news and press about, is about these sort of larger models that are trying to predict how people are going to, how the disease is going to spread through the population. But that's not the only modeling that there is in epidemiology. There are people who model at the chemical level, there are people who model at the cellular level. How does cancer spread in the body, or how does neurological models spread? And there's even all the AI stuff. On the side, what I would love to do is work on the concept of how neurons actually work, which is different than exactly the way AI is built, right? I mean, it's built on that concept. So there are people who are working on those types of things, which might have both biological importance as well as relevant economic and other factors, right? And so you can call that, it may not be exactly what you're defining in terms of epidemiology, but epidemiology and ecology and evolutionary biology are all large, broad concepts that in which you can do a lot of interesting things.
Very interesting. Thank you so much, Eili, for sharing this with us. Very interesting. So I would like to thank everybody for sticking around until now. We're 10 minutes over our original time that we had planned. Thank you very much to all of you for joining us and for sharing your views. I know these are busy times, as I said at the beginning, so we really appreciate you joining and giving us such interesting insights on this very, very relevant topic right now, which I guess COVID-19 has made modeling very popular at the moment. So me not being a modeler myself have gotten educated at some point by working with Eili and others. So thank you very much. Have a great day, and we'll see you on our last webinar, which will be sometime in 2022. Thank you.
Thank you.
Thanks.
Goodbye. Thanks.
Thank you. Bye.
Thanks.